So we are very, fortunate, and thank you very much, Peter, to have agreed to come in and talk to us today. So for those that doesn't know Peter, he's a physician and a scientist whose research and writing explores the quirks of human nature that influence our life. And I couldn't do justice to him in only 30 seconds. So with no further introduction, thank you for your work, and thank you for being here. So, Peter Ubel. And then I don't know if you just can take these and start circulating. Yes, I will. They'll shut that for you.
All right, I want to start with a quick decision. I want you to imagine that you're a woman with breast cancer, early stage breast cancer. You've just had surgery to remove the cancer. And now there's a new treatment that can reduce the chance of a recurrence, a local recurrence. One randomized trial established this treatment or gave evidence for its benefits and risks. And here they are. Without this treatment, you face a 15% chance of a local recurrence of the breast cancer. That would mean no distant metastasis, but you need a mastectomy to take care of that recurrent cancer. With this additional treatment, that risk will go down from 15% to 8%. The downside of the treatment, one is that it takes time, it's got some immediate side effects, but the biggest issue is more long-term side effect of breast fibrosis that would cause part of your breast to contract, maybe you feel a little like scar tissue, it might pucker on the outside, it might be a little bit painful, have some discomfort. And in your case, without this treatment, you face a 10% chance of fibrosis, and with the treatment, you have a 30% chance of fibrosis. So cancer recurrence down from 15 to 8%, fibrosis up from 10% to 30%. I know you need more time, more information, etc., but based on that, how many of you would take this new treatment? And how many of you would not take the new treatment? All right. All right, I am going to not use slides. I am not going to use notes. I've not told this talk before, so I will stumble through. But what I want to do is mainly tell you a story. And there's a high hazard with that. In law school, they teach that great cases make bad law. By that, they mean a great case would be one with all these amazing, fascinating circumstances, and if you build a law that would prevent those kinds of circumstances from being effective in the way that case was, you're going to end up with terrible laws. In science, they teach you that the plural of anecdote is not data. And so you have to be very careful about taking a story or a series of random stories and trying to generalize from it. I'm going to ignore both of those teachings. I'm going to tell you a story, and I'm not going to pretend that it's data. And it is a story with some extreme elements in it, but I actually think it's those extreme elements that help me generalize from that story to some more bigger truths. And they're specifically truths, I think, that should reveal some of the limits of patient empowerment, some of the dangers of relying on informing patients as the main way to achieve shared decision making. And I think point out that if we really want partnership between clinicians and patients to make decisions, we need to concentrate on both ends of the stethoscope. We need to probably intervene more on clinicians than we have been. That's going to be my thesis. That's the big one. The story that begins in May of 2011. And a woman lay anesthetized on an operating room table, a 44-year-old woman with an early stage breast cancer. The surgeon had just removed the tumor from her left breast and had removed 2 lymph nodes from her left armpit. That's called the sentinel node biopsy. This is the point of the surgery where the surgeon would either close up the wound to be done or would go in after more lymph nodes. But the surgeon was nowhere to be seen. He'd left the operating room. He was talking to the woman's husband. He said, "We have a decision to make. I have bad news for you, Paula. It turns out one of her 2 lymph nodes had a 1 centimeter metastasis in it." "Oh," says the husband, kind of surprised. "And that means we have a decision," he said. "We have to decide whether to go after more lymph nodes or not. What do you think Paula would want me to do?" sure what she'd want. We can finish the surgery today, wake her up, and if she does want me to go in after these lymph nodes, which by the way I think is the right thing to do, we'll have to go back a week from now. And what I can tell you is that this husband was both distraught because he just found out his wife had metastasis, and he was angry that the surgeon hadn't spoken to me before then about this potential decision. So I lay there, I stood there, my wife was laying there, in a position I never anticipated being in, and one I didn't want to be in, that I was kind of forced to make a decision for her that was completely predictable that we might face it, because they were taking 2 lymph nodes. And there was a chance that one of those lymph nodes would have a tumor in it. Very predictable that this is something we could have talked about beforehand. And so the question here is, how does a really prepared spouse in my circumstance, right? I'm a physician, kind of obsessed with decision making. I'd actually done research on breast cancer decision making. Before this moment, I had spoken to a bunch of my friends who were breast cancer researchers. How did this spouse, my wife is not a physician, she's way more powerful than that. She was chief of staff at the University of Michigan to the head of the health system. She basically fought with department chairs for a living. She was not intimidated by people with medical degrees or white coats or stethoscopes. And she knows it well. She's not, you know, a shrinking violet. So probably as assertive and informed and knowledgeable and empowered group, you know, patient and spouses you could have found, and here we were in this absolutely unacceptable situation. And the question is, how did that happen? And I think when I tell you a little bit how we got to this point, it's going to bring out a bunch of issues about, I think, the limits of patient empowerment. So the story clearly begins at one point with a mammogram. Mammogram had revealed a 1.7 centimeter spiculated mass in my wife's left breast. Spiculated means it's not a little round, benign looking like cyst, but it has like angry little tentacles, like it's trying to just branch out. So it's already kind of a bad looking mammogram. Biopsy confirmed what the mammogram suggested, which was that it was a breast cancer. Paula, at that point, sent out an email to all her friends to tell her what was going on. The subject header of the email was shit. She told people what the diagnosis was. The message ended with P.S. I hate pink. She's also a redhead, and really pink clashes with her whole coloring, right? So we got the bad news from the biopsy, and what we knew from the size of the tumor, 1.7 centimeters, and the fact that no other tests showed any distant spread, was this was early stage, and that meant that Paula, with my help, would face a choice between mastectomy and breast-conserving therapy, or which is lumpectomy plus radiation. We read the IMDF decision aid. Not content with that, we went to a bunch of different websites. Of course, we had friends to draw upon. I had medical knowledge to draw upon. We got pretty damn informed. And through that process, Paula developed a pretty strong early preference for lumpectomy. But that depends on more than just her preferences, because there are medical issues and cosmetic issues that determine whether lumpectomy is feasible. So we were eagerly, awaited the visit with the surgeon to discuss this. The surgeon was a great guy, very impressive credentials, more letters after his name than in his name. And early in the meeting, he examined her breast, and he says, "It feels a little bigger than 2 centimeters." And then continued to examine and talk. And the next minute or so was kind of lost to me, because prior to the visit, in my reading, I looked at breast cancer staging, and it turns out stage 1 is less than 2 centimeters. Stage 1 is the best, and stage 0 actually is the best, right? But stage 2 begins, a tumor that's greater than 2 centimeters, et cetera, whatever. And now, so frankly, I know, rationally speaking, that these stagings, you have a continuum of the size of the tumor that is really arbitrary where the cutoff is, and 2.0 clearly can't have been exactly where biology, right? Not where biology really changes, as you mark that kind of shit, right? But in there with my wife, it was like he comes in there, quick little examination, and all of a sudden he has just given my wife a stage 2 cancer diagnosis. And that's what I was left. I was lost for him, and it's just like, oh my God, it's worse than I thought. Why is this relevant? One is, as we, patients and spouses, get more informed, we kind of get partial information that we attach lots of meaning to, and if clinicians aren't aware of where their patients are coming from, or what their prior perceptions and beliefs are, it's really hard for them to know how their words are going to sound to the patients and the crazy spouses that are in the room. It's something that's pretty easy to figure out. Ron talked about the idea of teach back. You don't even have to wait for the teach back moment. Sometimes you can start early in a visit to get an early perception of what can tell me what your understanding is of what we're doing today and what your understanding is for your illness. It's a great way to know what patients think and believe and understand, what they don't. It can really direct a conversation. Angie Fagerlund has been conducting research on prostate cancer decision making with men diagnosed with early stage prostate cancer, face a choice between radiation, surgery, and active surveillance. And in those visits, there were 280 some encounters, and 2% or less where you had physicians assessing patient understanding. It was staggeringly uncommon. If you want to have true partnership between patients and clinicians have to understand where patients are coming from. I mean, we can't read patient minds. We can ask people what they think. In any case, the point of this visit was not for him to deal with my emotional needs about my wife's staging, okay? The point was to decide whether Paula could have a lumpectomy or not. And the surgeon was concerned that the size and especially the location of the tumor meant that she would not have a good cosmetic outcome with lumpectomy. This was very disappointing to Paula. And so she pushed back, asked a bunch of questions to see, well, is this an option? Is that an option? Can you do a partial implant? Can you do a partial reconstruct? All these kinds of things. And the surgeon was really good and patient in talking through these options with her. And he said, you know what I want you to do is actually meet a plastic surgeon and learn what your alternatives are. We had two things that was looming on Paula's mind for the visit. One is, I hope I need a lumpectomy. Now we knew we wouldn't find that out yet. The second was, I really hope I don't need chemotherapy. So as we were finishing the visit, she says to the surgeon, well, tell me, do you think I'm going to need chemotherapy? He says, well, I'm not an oncologist, so I really can't say. This, by the way, is where that answer should have ended. But he said, if I had to guess, I'd say chemotherapy is in your future. Really. Sometimes us physicians have to know when not to talk. So we walked out of that visit, Paula disappointed that she wasn't sure she'd get a lumpectomy, very disappointed that she was sure she'd get chemo. I'm going to tell you, she ended up with a lumpectomy and no chemo. Okay, let's go from the surgeon's office to the plastic surgeon's office. Paula's sitting up on an exam table, and you know those terrible hospital gowns where your butt's always hanging on the back? Well, when you have breast cancer in the plastic surgeon's office, they kind of switch that gown around the other way so they can examine the breast. So she's sitting up there kind of, let's say, exposed. And the surgeon comes in, brief introduction, very quickly starts examining her, and agrees that this is not going to be a good cosmetic outcome with a standard lumpectomy. He's talking kind of fast and a lot of information, but the crux of it was that there was another approach he could do, a new approach called oncoplasty, great name, and in it, he could, with her left breast, come in and make the initial incisions for the operation, then leave the room. The general surgeon would come here with the tumors, the lymph nodes, etc. Then he'd come back in the room. And because the breast would now be quite asymmetrical from the removal of the tumor, he would rearrange the remaining breast tissue. And so she could get a lumpectomy in that case and would have a breast reduction and a newly shaped breast. Actually, Paul was ecstatic about the idea of a breast reduction. And he said, at the same operation, he could go over the right breast and do a reduction there so that they're symmetrical. So we talked about that. And he said, there's a downside to that. You're going to leave the operation with symmetrical breasts, but then you're going to get radiation treatment. And maybe by about a year after radiation, you might notice some shrinkage, contraction of the left breast, and so they'll be asymmetrical. So that's the downside. He said, now in your case, he says, I don't think that's a big issue because you've tolerated a fair amount of asymmetry for a while. I see, you know, that this such one breast is 96 grams larger than the other. All right, I don't want to get too far into TMI territory here. But I spent a lot more time looking at and, what's the term, palpating my wife's breasts than he had. And within this brief exam, he not only notices an asymmetry that I had never noticed, or never appreciated, but he's got it down to the gram. I think he was exactly correct, of course. And so he then went on to explain several other approaches. approaches, what mastectomy, reconstruction, et cetera, et cetera. And the information started flying by pretty quickly now. He was 45 minutes late for our appointment, so I think he had some catching up to do. I am there trying to ask questions. Paul is there just really happy to think she might be able to get a bilateral breast reduction. And I said, no, if I understand correctly, there's 4 options here. And the first is, the hand comes up, and he says, our best option is immediate bilateral reconstruction. I can rearrange my schedule to go with the surgeon, and so we'll set up a time, and he's gone. It was stunning. I mean, I'm not the most assertive person in the world, but I was in there trying to get a word in to understand our options. And that just wasn't part of his agenda. And I really didn't understand the other options, and didn't have real time to figure it out. And but Paula was quite happy with the decision that he made, or they made, or she made, and I don't know who made it. But the decision was made, and we were off the next stage of the journey. It's really important that clinicians know how to speak at a pace that patients can understand, and know and have the time to answer questions when we have them, or if they can answer the questions, then they find an allied professional who can. And no decision aid covered these. The oncoplasty hadn't made it onto the decision aid. It's pretty new, right? So this is all. I was completely bewildered at what's going on. And I think if I'm bewildered, what is a layperson going to feel like in that circumstance? Again, going back to Angie's prostate cancer study with Karen Schur. Karen, where are you? Raise your hands. Karen's a medical student at Duke, who's been analyzing the encounters that happen between urologists and prostate cancer patients. And there we find some good news and some bad news about physicians' ability to explain things to patients. If you went back 30 years ago and a patient had cancer, actually when they had really advanced cancer, 90% of docs said, I don't tell them they have cancer because they'll just feel bad. That was the dominant practice in the United States. That's changed. Now you go into a urologist with early stage prostate cancer, and you're not going to leave that room without a pretty extensive discussion of your treatment choices, the pros and cons. Not always completely balanced, not always perfect information, but extensive amounts. In fact, crazy amounts of information, right? With very little time to ask patients, make sure patients understand, with no, now tell me what you heard me say, I want to make sure I explained it well. You don't get to teach back almost ever. With instead things like, any questions? Which makes people just kind of go, no, because they don't want to look stupid. And with a vocabulary, so a typical encounter would start with the doctor breaking the bad news that man had cancer, and then rather than give a person time to digest that emotionally, would launch into an erudite discussion of their staging, which is in prostate cancer, it's a Gleason score trace from 6 to 10. 6 is the lowest, 10 is the highest. One patient said, should 0 be the lowest? Well, 6 is the lowest, 10 is the highest, 6 is early, 10 is advanced, 7, 8 are intermediate. Now, it depends on what looks on the microscope. In your case, most of the cells are 3+3, but some are 3+4, just enough 3+4 for it to be 7. So you're at Gleason 7. If there had been any less 3+4s, it would have been Gleason 6, so you're really just early Gleason 7. Right? Clear? Questions? All right. What it is, it's an earnest effort to educate. And in fact, in this case, it was an effort, I think, from the urologist to say, dude, you barely got past Gleason 6, which is barely a cancer. This is the best. If you're going to get prostate cancer, this is pretty darn good. But instead, it was put into this foreign language. So again, I was getting confused in this plastic surgeon's office. Imagine what happens to lay people. And if you're going to improve shared decision making, you've got to understand what happens in the encounter. In fact, we have to intervene on the encounter to help physicians know how to better educate. Okay, so that was plastic surgery. What's next? Surgery. Now it's the operating room. Something really wonderful happened between our surgery outpatient visits and the day of Paula's operation. An article came out in the New England Journal of Medicine that was a result of a randomized trial of women with early stage breast cancer who had these sentinel node biopsies of those 2 lymph nodes taken out. And what they did was, when they found that there was cancer in one of those lymph nodes, they randomized women to either have a bunch more lymph nodes removed, or to remove no more lymph nodes. And then the woman received chemo or radiation or whatever treatment followed. 15 years later, no difference not only is it more surgery and more chance for local infection, etc., you have a chance of lymphedema, which means the fluid doesn't drain well from your arm, and you get painful, swollen arm. I mean, it can be a really miserable condition that gets out of control. It means you're wearing a tight sleeve on your arm every time you go on an airplane or exercise, and if you start experiencing lymphedema, you wear that tight sleeve all the time. Think of it like Lycra at 10 times its normal strength. So it was wonderful news because now I knew Paula would not need to go through this procedure. So you can imagine my surprise when in the middle of the operation, the surgeon comes up to me and says, "Do you think we should remove more lymph nodes?" You can imagine his surprise when I start quoting the New England Journal article back, right? What about that study? Oh, yeah, the New England Journal study. He says, well, I'm part of that study, actually. I analyzed the data. And then he goes to explain that Paula had more severe, more advanced metastasis than was typical in that study. Hers was seen in a frozen section there. They were being seen in a permanent section, yada, yada, yada. So basically he starts just selling me on, no, she's someone who still needs the lymph node dissection, but it's, her decision to make. Oh, by the way, what decision do you think she would want to make? This was probably quadruply ironic, but here's one of the type of ironies that's going on at the time. By the time that Paula experienced this diagnosis, I had started writing a book, Critical Decisions, which is floating around right now. She said that her favorite of me was that I could write a chapter about her illness before I finished the book. It's really nice to write. But by that time, I had written a bunch of draft chapters, and in chapter 1 of the book, in fact, I told a story about another woman who had breast cancer and another husband who was put into kind of an awkward position in the middle of the operation. This is a woman whose primary care physician felt a mass in her breast one day, didn't tell her he felt anything, just said, I'd like to go see a surgeon this afternoon. Okay, so she sees a surgeon, who examines her, and then at least says, well, there's a mass here, it could be cancer. She goes under anesthesia, and they do the biopsy then, and see that it's cancer, talks to the husband and says she needs a mastectomy, and they did it. So she woke up with everything removed. And it was a radical mastectomy. This was 1975. Radical mastectomy means you remove the breast, muscle, connective tissue, lymph nodes, maybe a little bone, get close to bone. Really awful procedure. That surgeon knew the NIH was about to release results of a trial that compared that radical mastectomy to a modified radical mastectomy that was, while still a big procedure, was much less aggressive, and that had shown no difference in survival. But that surgeon didn't believe the results because, the more you remove, it's got to be better, right? And didn't think that the spouse or the patient deserved this information because the doctor was in charge. And the doctor was so much in charge that it didn't matter that his patient was the First Lady of the United States, Betty Ford, and her husband was Gerald Ford. So 1975, that's how doctors made decisions, and that's how powerful we doctors were. We ordered around the President of the United States, right? So I've written up that story. I learned that almost throughout the history of breast cancer, once you do a more aggressive surgery versus less aggressive surgery, the less aggressive surgery is almost always just as good because we're understanding it's more of a systemic disease than local, etc. Now all of a sudden, here I am in the middle of an operation with the same thing. And so inside me, I'm thinking of the Betty Ford story. I'm mainly thinking about crap. My wife's got a positive node. It's awful. Not a great situation to have to make a decision. I was thinking, I can't believe that the surgeon's right that removing more lymph nodes is going to be the way to go. On the other hand, he was kind of pushing for it. And then I tried to think, well, Paula won. I know she hates going under anesthesia. She's had several hip operations in the past. She wakes up nauseated and miserable. It's awful. So the thought of waking her up and then having the surgeon convince her to get the lymph node dissection, which there was a decent chance he would. On the other hand, do I decide without her what to do? This is an awful position to be in, right? And I don't think I made the right decision. I finally just said, okay, go remove lymph nodes. And to my wife's credit, she said, oh, thanks, that was the right decision. And one thing she was doing is, here, she's the one with breast cancer. She's trying to make me feel better about the situation, right? So he went and said, okay, so I'll take out as few as I can. What does that even mean? All right, now let's fast forward. Paula's recovered from the surgery. She's been a beautiful spouse and maybe not feel super guilty for the decision I was forced to make. And now it's time to meet with the radiation oncologist. The junior radiation oncologist was wonderful, described what things would be, actually in English, but she had all day to do it. Then the senior oncologist came in, re-explained things again. No rush. It was really, really impressive group of clinicians. The senior radiation oncologist attending at one point then says, okay, then so what we'll do here, we're going to do 5 weeks of radiation to the whole breast and also to the arm, the axilla, because of your lymph node. And now normally we would do a 6th week of radiation to where the tumor was, but because you had that reconstructive surgery, we no longer know where the tumor was located, so we won't do the 6th. So that means we can start your radiation on Thursday, da 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 da. Did we catch what just happened there? We did not know when we or he or they or whoever decided on the oncoplastic surgery, nobody told us that would mean there's no option for a 6th week of radiation. So, you know, for shared decision making to work, clinicians have to anticipate branch points in the decision, and you have to think what the consequences of the decision from now are for subsequent decisions. Processes can do a lot to take care of this, like no decent cancer center should allow a woman to go under the knife for treatment of breast cancer without having her meet with a radiation oncologist beforehand if she's thinking of getting a lumpectomy. I mean, how, honestly, because you're going to get radiation if you're getting a lumpectomy. How could you, I mean, that should just be standard, right? So processes could do something to improve this. But clinicians just imagining what matters should is important. And so we need to do a better job of teaching clinicians when there's a decision where a reasonable patient might want to know something before they make a choice. Now, there's some weird things going on here also. It was clear to me that if Paula had not had that reconstructive surgery, this deal would have been, first we're going to do 5 weeks of radiation, and then we're going to do a 6 weeks of radiation to where the tumor is, boom. It would not be, and then we have an option to do a 6th week of radiation. So it was clear that there was a standard of care. This was a no-brainer. It's what I guess Gordon Guy would say, you know, we can't make everything into a shared decision-making discussion. There are some things where it's really obvious what the trade-offs are, right? So basically we had standard care ripped away from us without knowledge. We go home, we email our friends, tell, kind of update, we give regular updates on Paula's status. And one of my friends, Reshma Jagzi, emails back to me. Reshma is a radiation oncologist at the University of Michigan, one of my mentees who've done a bunch of research together on gender inequality in academic medicine. She's just a great clinician. She's a breast cancer radiation oncologist. She emails right back to me and says, I'm surprised there's only 5 weeks radiation, normally it'd be 6. So I explained her email back, explained it to her, and she says, I think trying to make me feel better. Oh, well, it's not really that big of a deal. Right? I'm like, right, just tell me, can you send me some articles, Restaurant? I'd like to see where this 6 came from. Well, the short version of this is, I got hold of the randomized trial that established the 6th week as the standard of care, and I extrapolated from the graphs in there, because it's a bunch of women, different age groups, different sized tumors, but from that I extrapolated and I figured out the trade-off. The trade-off is what I presented you all with at the beginning. In Paula's case, 15% chance of local recurrence without the 6th week would drop to 8 with the boost therapy. But it would take her the fibrosis from 10% to 30%. You did not pass the Gordon Guide test of every sane patient would say, give me the 6th week. And yet right now, today, and tomorrow, there will be radiation oncologists just offering 6 weeks of therapy to people and not saying, and we have an option for a 6th week. So we have really important decisions where patients should be thinking about trade-offs and they're not being given the chance. And again, no decision aid that I saw laid out those trade-offs. Okay? And in fact, it's really hard for any decision aid to do it because the trade-offs vary. The numbers depend on what your local recurrence rate is. Fibrosis rates tend to be more constant, but that can vary by age. I mean, it's complicated, right? So this is a really big challenge, I think, to share decision making. If we focus on the patient under the stethoscope, and we try to inform them as much as we can, we try to activate them, we try to show that their values are important, that you need to ask questions. What's going to happen? They're going to come to clinical encounters scared, half naked, not exactly a position of power. You're going to have a clinician talk to them in words they don't understand. Sometimes about information they've already learned from a decision aid, but not necessarily in the same words, so you might not know that they map on together. Sometimes with new information that contradicts what you just thought you understood. Sometimes with a whole new procedure, oncoplastic reconstruction, you hadn't even heard about before the visit. And patients have to try to absorb that information and get engaged in what they end up doing. And this is what happened and most of whom are mute for the vast majority of the encounter. And so we have to work on our decision tools for patients, have to do a better job of teaching people, modeling behavior about how to engage. But I think we have to find ways to get physicians to know how to help patients engage. Simple things like, what if this was standard language for a doc? First off, the teach back that Ron talked about. What if you just, taught physicians, anytime you explain something, ask the patient to explain it back to you when you're done. What would happen if people did that regularly? Number one is, they very quickly realize how much what they're saying isn't getting through. Over time, they'd probably start refining their message, simplifying it, to where a higher percentage of patients are spitting back a good understanding. And third, with any given patient, they can then correct misperceptions and understanding. Right? And I think in the long run, it's going to shorten encounters because we're going to get better at explaining things. The second thing that physicians can do in all these decision-making encounters is once they make sure the patient understands the trade-offs, which hopefully the physician has identified, right? They say, okay, now I'm the expert on medical facts, but you're the expert on you. And for me to help work with you to find the best choice, I need to understand more about what you care about, what's important, etc. So I think if we just made that language just a regular part of the encounter, patients wouldn't have to come in like, I have power and I'm going to assert myself. Because a lot of patients, frankly, that's not going to be comfortable to them. But when the physician invites them to talk because I need something from you that will help me essentially diagnose your preferences, they're invited to participate. And if you just had better two-way communication, I think that is really what shared decision-making is about. Shared decision-making is not a decision-making. Shared decision-making is some set of interventions or culture or something that causes a dialogue across both ends of the stethoscope so that both parties understand each other better and can make a decision together. All right. Let me tell you where Paula's story ended up. It hasn't ended, of course, right? She's now on, she had a lot of hormone receptors on her tumor, so she's just finished the 2 years of super hormone suppression, as the oncologist described it to us. This is your hormones now, this is the hormones of a woman in menopause, and this is where we're going to take your hormones for treatment. Okay. So she's done that for 2 years now. She'll be on toxin for the next 10. She did not need chemotherapy. It was wonderful news. She was able to have lumpectomy, as we talked about. And then, really, interestingly, when I ended up talking to my friend Reshma, the radiation oncologist, about this whole boost controversy, she kind of dug in a little bit and said, I think they can still do the boost if they want to. And she ended up calling up our radiation oncologist and explaining to her how she thought this was still an option. Again, not something that most patients or spouses would have the resources to be able to do. So now Paula Ellison did have a choice about whether to do the boost or not. The majority of you in this room would not have done it when it was an unlabeled description that I gave you, right? I think, and I don't know honestly, if this had been presented from day one as, here's the standard is 5 weeks, and here's something you can decide whether you would also want an addition, what Paula would have done. But I'll tell you, when it was an option, then normally that would be the norm, the social, clinical norm. When it was something that was taken away from her, and scarcity is a very powerful psychological impulse, right? You want to sell a product, make sure there's not enough on the shelves in November, and you have a very popular Christmas toy, right? So scarcity is very powerful. And so by the time that 6th week was back on the table, literally, I guess, she was very glad to take advantage of it, so she ended up receiving that. So shared decision-making. I think, I think we all share the same goal of trying to get what patients care about to be a bigger part of the decision-making process. But we have to really focus more on the process than I think we have done. I mean, we, like all of us, I've developed decision aids, and I've seen them fail miserably sometimes. And I think for us to really take this to the next level, we need really to improve the clinical encounter. I'm really eager to hear your questions and thoughts. Thanks a lot.